So we will go to molecular changes and what are the IHC markers, surrogate IHC markers. I'm not going to read about all these things. I will just mention important things. Pleomorphic adenoma, PLAG1 and HMGA2. For carcinoma X pleomorphic adenoma, TP53, I showed you a picture that is very, very important. For epithelial myoepithelial carcinoma, they are telling HRAS mutation is 25% it is expressed. This percentage prevalence is very, very important to remember. For basal cell adenoma, as I told you, 70% they express beta-catenin. For mucoepidermoid carcinoma, I told you MAML2, either with CRTC1 or C3, 80% with CRTC1 and MAML2. For salivary duct carcinoma, it is HER2 expression and androgen receptors. For acinar cell carcinoma, I told you NR4A3, 84% expressed, very good marker. For adenoid cystic carcinoma, I told you MOIB. For secretory carcinoma, NTRK3. For clear cell hyalinizing, it is EWSR ATF1. For polymorphic adenocarcinoma or cribriform adenocarcinoma of minor salivary glands, we don't have markers, but they are having mutation. Molecularly, you can go for PRKD, either 1 or 2 or 3 rearrangements with arid 1A. Okay, these are all more molecular. We don't have markers right now. So what is the way to remember? As I told you initially, whenever there is a molecular marker, you have to see whether it is diagnostic, prognostic, or theranostic, which is therapy related. Okay, for pleomorphic adenoma, PLAG1 and HMGA2, we have IHC. It is helpful in diagnostic and therapeutic. For mucoepidermoid carcinoma, I told madam to send it for FISH for MAML2 fusion. It is both diagnostic and prognostic. For adenoid cystic carcinoma, MOIB is available in IHC. It is diagnostic and prognostic. For secretory and all these markers in future, they will be predictive. Theranostic use also will be there. For secretory carcinoma, it is NTRK, basal adenoma, beta-catenin, both available in IHC. Okay, take a screenshot of this. For acinar cell carcinoma, we have NR4A3. For salivary duct carcinoma, we have androgen receptor and HER2 receptor. For polymorphous, I told you PRKD1. For clear cell carcinoma, I told you UWSR and ATR. Okay, but unfortunately, IHC markers are not available today. Tomorrow, the features may change. For myoepithelial carcinoma, again UWSR1. For epithelial myoepithelial, it is HRAS. Take a snapshot of this. So this is the composite picture I thought I will show you. For pleomorphic adenoma, all are nuclear marker, most of them. Please remember that. HMGA2 and PLGA1, PLAG1. PLAG1 is more specific. For basal cell adenoma, it's beta-catenin. For adenoid cystic carcinoma, it is MOIB. For acinar cell carcinoma, it is NR4A3. For secretory carcinoma, it is PanTrack. For salivary duct carcinoma, like comido-DCIS in the breast, androgen receptors and HER2 nice 3+ membranous positivity. Take a snapshot of this. It's a very good. I love this. I took it from many articles and many images. To get this one image, please believe me, you have to see more than 100 images to get the best for you. So lastly, but not leastly, PTNM staging and meeting the guidelines of NCCN. Very, very important. Okay, PTNM, it's like a big table here. It's very difficult to differentiate. So you have to come up with the features. What are the very, very important things? Size between 2 to 4 centimeters. Extra parenchymal extension, which is present grossly. Microscopically, when you see, it doesn't come under T4. If they see grossly, then it is T4 and destructive invasion. Okay, so depending upon these three, you classify them into Tx to 4b. Lymph node, again, there are a lot of criteria are there, but you decide what is the very important. Is it a single node or multiple node? Is the node metastasis size, is it less than 3 centimeter, 6 centimeter, or in between 3 to 6 centimeter? Is there actually any extranodal extension? Is it unilateral or bilateral or present in the contralateral? These are all the 4 points, very, very important to go for staging. And please don't try to memorize these things. Humanly not possible. Whenever you see tumors, you sit and see. The more you use the system, the more you will get comfortable. Distant metastasis, PM0, no distant metastasis, PM1, distant metastasis. And one point, if you have to remember, if it is a non-regional lymph node, it doesn't come under nodal. It is a distant metastasis. For example, salivary gland tumor with axillary lymph node, it is metastasis. It is not PTN3. I hope you all understand that. And then you put everything under the staging, and you come up again with a simple thing. Stage 1, very early stage cancer, less than 2 centimeter, no lymph node. Okay. Stage 3, more than 4 centimeter or 1 lymph node positive. Like that, you write down the value and point so that you can remember, because this staging system is very important for the treatment purpose. Okay. And this is what I want all of you to sit with your oncologist and see. This is a NCCN guideline. Okay, we follow NCCN guideline, and they will have flow charts like this. And for practical purpose, I just cut short what are the points we need. Whenever there is a FNA biopsy, you see whether it is benign, malignant, or carcinoma or lymphoma. That's the main difference. Lymphoma, you refer to non-Hodgkin's lymphoma recommendations. If it is carcinoma or benign condition, go for second one. If it is complete resection, is it benign or low grade? When do you call low grade? If there is tumor spillage or perineural invasion, then you have to give radiotherapy. See how we play a very important role in deciding radiotherapy. When we see perineural invasion, radiotherapy has to be given. When it is adenoid cystic carcinoma, we have to give radiation. When it is total complete resection and the cancer site is major or minor salivary gland, you have to go to the next recommendation. When resection is not possible in T4B, we have to give for radiotherapy. Okay. And when the resection is possible and when it is parotid, no adverse features, just to follow up. When it is adenoid cystic, it is RT. And this is very, very important. Adverse features. All the adverse features are diagnosed in pathology, intermediate or high grade tumor, close or positive margin. When you call it positive margin, the tumor cells are present at the margin. When do you call close? If it is less than 1 millimeter. Today it is 1 millimeter, tomorrow it may change. So you have to keep looking the literature. If it is less than 1 millimeter, we call it negative margin, but they have to go for radiotherapy. So this is very, very important role for pathologists. When there is neural or perineural invasion, when there is lymph node metastasis, when it is lymphatic and vascular invasion, all these conditions we have to go for radiation. When it is incompletely resected or gross residual tumor, again they have to go for radiation. When it is completely resected and it recurs, again you look for adverse features, which we went through in the previous slide to decide for radiation. And this is more important in the new targeted therapy. Okay, if it is androgen receptor positive, if it is NTRK therapy, PanTRK positive, when it is HER2/neu positive, when it is MOEB positive, we have specific markers. Okay, so I kindly request all. Probably in pathology exam, they are not forcing that much. But when you start practicing, you please go through NCCN guidelines or any guideline they follow in your hospital, and go through what are all the pathological features that will have a implication on the treatment, and you highlight that in your report. So that brings the end, the take-home message. These are, we can talk whatever we want, but clinician want to know whether it is low grade tumor or high grade tumor. Okay, please take a snapshot of this. These are all very important for the clinicians, because the prognosis is very, very important on the histological type. For example, actinic cell carcinoma, very good prognosis, whereas squamous and adenoid cystic, very bad prognosis. And this is the take home message. So you divide them salivary gland into 4 compartments: acinar, intercalated, striated, and intra and interlobular or excretory duct. Acinar cell carcinoma and secretory carcinoma in the acinus. Basal cell adenoma, pleomorphic adenoma, adenoid cystic carcinoma, polymorphic adenocarcinoma, epithelial myoepithelial carcinoma in the intercalated area. Warthin tumor and oncocytic neoplasm in the striated ducts. papillary carcinoma, or papillary neoplasms, including papilloma, papillary carcinoma, epidermoid carcinoma, squamous carcinoma, mucoepidermoid carcinoma, salivary duct carcinoma in the ductal end. Myoepithelial carcinoma from the myoepithelial cells, sebaceous tumors from sebaceous cells, lymphadenoma, and carcinoma arising in lymphadenoma from the lymph nodes. So, genetically or molecularly, you divide them into acinar end and ductal end. Acinar end is OX10 positive and ductal end is OX10 negative. And the specific markers are NR4A3 for acinar cell carcinoma, PanTrac for secretory carcinoma, beta-catenin for basal cell adenoma, PLA-G1 for pleomorphic adenoma, MOEB for adenoid cystic carcinoma, S100 for PAC, epithelial myoepithelial carcinoma, use epithelial and myoepithelial, which is P40, Warthin tumor, oncocytic neoplasm, anti-mitochondrial antibody, squamous cell carcinoma, P63 or P40, mucoepidermoid carcinoma, FISH for MAML2, salivary duct carcinoma, androgen receptor and HER2/neu, myoepithelial tumor P40. When it is differential of squamous and myoepithelial, markers won't help you. Sebaceous tumor EMA. And that's all about this lecture. I kindly request you to take a screenshot of this. Super. These are all again my references. We will just fly through 15 cases. Okay. So 64-year-old male, upper lip tumor, diagnosis. Madam, I will give 2 seconds, madam, in the chat box. Let them feel free. Yes. Delegates feel free. This is upper lip. Okay. See the mucosa or the skin side of the upper lip. See the well circumscribed tumor. See the interconnecting tubules. And all interconnecting tubules. Any diagnosis, madam, there?
Canalicular adenoma.
Super. Canalicular adenoma. Good. Any name, madam? First answer, name.
Uma Devi Srinivasan. Dr. Uma Devi Srinivasan.
Congratulations, Uma Devi. You please buy a Cadbury's and eat by yourself. It is our prize for you. We can't do better than that. Or Anand will send you one Cadbury's.
Yes.
So canalicular adenoma S100 and CK7 positive. I want to skip the theory part of it. Okay. So case 2, 52 male. So this is a lymph node. This is the salivary gland, some minor component, and this is a somewhat ill-defined margins. It shows multiple patterns, some papillary, some cribriforming, some glandular pattern. Diagnosis, some papillary pattern, architectural diversity, infiltration, and cytologically they look very bland. I give you the clues. Diagnosis.
Polymorphous adenocarcinoma. Polymorphous.
Super. So glands, papillary pattern, non-specific, and remember this is roughly not that much of hurricane luster. It is forming there. Okay. Remember the targetite pattern and remember the triad. Case 3, 25 female parotid lesion. Here you see this salivary gland margin is not very regular. And when you go to the high power, it is having 2 components. They have pseudocartilaginous component and a high-grade malignant component. And that high-grade malignant component is very cellular, shows some necrosis. And so the diagnosis.
Mucoepidermoid. Doc R has replied as mucoepidermoid carcinoma. And there is another answer, basaloid.
No, how will you explain this cartilaginous area? Imagine you see only this.
Yes, carcinoma ex pleomorphic adenoma.
Yes, and you qualify myoepithelioma. These are spindle cells. Okay, I will show you more pictures. This is carcinoma ex pleomorphic adenoma, myoepithelial carcinoma. Okay, and I have to give the percentage just in case if the clinician asks. Okay, it's better. Myoepithelial carcinoma, in this case 30%. Okay, so here you can see the pleomorphic adenoma and carcinoma, and it's infiltrating at the margins, at the borders, and they are more spindle shaped. And when you do PLA-G1 positive in the pleomorphic adenoma side and P63 strongly positive, Ka67 very high in that area. Okay, so it is carcinoma ex pleomorphic adenoma, myoepithelial carcinoma type. Submandibular lesion, 15-year male. You can see the salivary gland here. And you can see the infiltration. Okay, see this here, infiltrating into the salivary gland. When you go to high power, these are very poorly differentiated cells. And I want to point to one thing. See the abrupt keratinization. Can you see the epithelial pearl? So abrupt keratinization. Okay, poorly differentiated carcinoma with the abrupt keratinization. Any diagnosis?
No, sir. Carcinoma explomorphic adenoma, again they have written.
Okay, good thought. So it's a poorly differentiated carcinoma in the HNE, but keep that in that abrupt squamous differentiation. Okay, that's very classic for this. See the squamoid areas. Can you all appreciate squamoid areas? Okay, abrupt, very abrupt. And the DD is poorly differentiated carcinoma, poorly differentiated squamous cell, sinonasal undifferentiated, nasopharyngeal carcinoma, lymphoma, Ewing's. And we do a lot of IHCs, they are all negative, but there is one marker called NUT, okay, nuclear transcription factor in testis, okay, that NUT is positive. So that's the diagnosis, okay. There is translocation 1519 and NUT IHC is nicely positive. And so the diagnosis is NUT carcinoma, okay. What is NUT carcinoma? This is nuclear protein in testis. It's a poorly differentiated carcinoma, but that abrupt keratinization is very, very important. Cell of origin, we don't know, but diagnosis is by FISH for the fusion and for IHC for the NUT protein. Okay, I know this is out of syllabus. Some, I think 3 or 4 slides are out of syllabus. I have not talked about it, but this NUT carcinoma comes under poorly differentiated carcinoma in the new WHO type. This is very common in the head and neck area. So in the sinuses, please keep it in mind. Poorly differentiated carcinoma with abrupt squamous differentiation. Super. Case number 5, 47 male peritonsillar area. Okay, infiltration is there. Some clear cell, some glandular structures, high power, you can see it very nicely. Luminal cells, abluminal cells, invasive malignancy, diagnosis. You can see the luminal and abluminal clear cells. Diagnosis.
Myopithelial carcinoma.
What about these? What are these cells? These are epithelial.
Epithelial myopithelial carcinoma, sir.
Yes, epithelial myopithelial carcinoma. Okay, P63, if you do, they will stain all abluminal cells, and when you do low molecular weight cytokeratin or CD117, they will take all the luminal cells. Case number 6, low power diagnosis, salivary gland invasion, some cystic degeneration, invasion into soft tissue, and high power tubular and attempted cribriforming. Diagnosis, adenoid cystic carcinoma.
Yes.
Okay. Yes. So this is the FISH for MOB, NFIP, and this is the immunohistochemistry for MOB. They can show tubular pattern, solid pattern, cribriform pattern, and basal cell adenoma, one of the DD, to make clinicians very angry in cytology. Ki67 and the MOB will be very, very helpful. Case number 7, parotid lesion. You can see normal salivary gland, some well circumscribed lesion, and you see more like small blue cells, isn't it? In this high power, you can see some nests of epithelial cells. And in the highest power, lot of lymphoid cells, some nests. Some of them are having sebaceous differentiation. And the nuclei are very bland. Diagnosis.
Sebaceous adenoma.
Super. Lymphadenoma, sebaceous type. You have to include lymph also there because a lot of lymphoid cells. So lymphadenoma, sebaceous type. Okay, high power. Great. Case number 8. This is again a parotid lesion, and this tumor is infiltrating. Again, blue cells and the irregularness. When you go to high power, see the Hyundai sign. Can you see Hyundai or Hero Honda? All costly car logos. They are atypical mitosis. Mercedes, okay, Honda, and very highly pleomorphic, isn't it? And the criteria for pleomorphism, go to the lowest, smallest cell and go to the largest cell. If it is more than 3 times, that is the criteria for pleomorphism. Okay. Diagnosis?
Lymphoepithelial carcinoma is given, sir.
Super. Okay. But this patient doesn't have any other mass. This is the only parotid mass. So this is the epidermoid carcinoma arising in lymphoadenoma. But that is an excellent diagnosis. And EBER you can do in epidermoid carcinoma in lymphadenoma, EBER will be negative. And P16, you all know all squamous cell carcinoma in the head and neck mainly classified into P16 positive and P16 negative. So this will be P16 positive. So this is the other picture, squamous cell carcinoma arising in lymphadenoma. Case number 9, parotid lesion. Thank God it is not coming in the frozen section. See, you can see the extensive squamous, some infiltrating islands are there. Some minor salivary gland elements are there. Some ducts are there. Okay, this is the low power view. In the high power, very irregularness, but they are all very mature. And see another again, the lobular pattern is maintained. Okay, diagnosis?
Necrotizing xylometaplasia.
Super, xylometaplasia, one of the very difficult diagnoses in frozen section. Okay, lobularity and absence of ATP. This is more like pseudoepithelioma carcinomatous hyperplasia. They used to call pseudoepitheliomatous. Why do you call it pseudoepithelium? It is a real epithelium, but it looks like carcinoma. That's why it is pseudocarcinomatous hyperplasia. And necrotizing xylometaplasia is the diagnosis. Squamous metaplasia and squamous cell carcinoma, P63 will be very helpful. Okay, in xylometaplasia, the basal cells are preserved, P63 positive, whereas in squamous cell carcinoma, P63 will be negative in the margins. Okay, but sometimes the even squamous cells can take P63. It's not very useful practically, but in this picture, it's very useful. Case number 10, submandibular lesion. Okay, salivary gland, widely invasive, lot of secretions. Let us go to high power. Some squamoid cells, some mucinous cells, some hybrid cells. Diagnosis. See, this is how you have to describe. The description should bring you the diagnosis. Priyanka, come on, Priyanka.
Secretary, sir.
Secretary.
Clear, sir.
Yeah, squamoid cells allar irukema. I agree, secretary is there, but I told you, mucin cells, intermediate cells, and squamoid
So they
cells.
mentioned mucoepidermoid.
Mucoepidermoid.
Mucoepidermoid. Okay, it's a low-grade mucoepidermoid carcinoma, intermediate grade and high grade. Okay, and we follow the AFIP system. Cystic component, less than 20 or more than 20, perineural invasion, necrosis, mitosis, more than 4 per 10 hyperfield, anaplasia or nuclear atypia. We give the score. The score is 5 to 6, intermediate grade, 0 to 4, low grade, more than 7, high grade. Case 11. Somebody asked the question also before, so this will tell the answer for that. Parotid lesion. Okay, lymphoid infiltrate, oncocytic cells with the lymphoid infiltrate, only oncocytic cells, but there is no capsule.
Warthin's tumor, Vanilla. Dr. Vanilla.
Yes, this
Krishna.
is Warthin's, but what is this? So it's Warthin's tumor with oncocytic hyperplasia. Remember, somebody asked, if you don't see lymphoid cells, when you see only oncocytic cells, what do you have to call? You have to see whether there is capsule or not. When there is no capsule, only oncocytic cell, it is oncocytic hyperplasia. When there is capsule without invasion, it's oncocytoma. When there is capsule with invasion, it is oncocytic carcinoma. Okay, so you can remember, see in this picture very nicely. This is the Warthin component. This is the oncocytic hyperplasia component. Probably they are all spectrum, but we have to name them differently. But who cares? It's hyperplasia and Warthin tumor. Patient should do very well. Is it male or female? Male. Remember, the Warthin tumor very common in male. Super. And antimitochondrial antibody positive. Case number 12. Parotid, female. Parotid gland. And some pink cells. Look at the lymphoid infiltrate at the margin. tumor associated lymphoid proliferation.
Acinic cell carcinoma, someone has replied.
Super. Okay, in this diagnosis, if you diagnose acinar cell carcinoma, give a DD. Don't be very committed. I know you took a chance here, but whenever you see lymphoid aggregate with a large pink cells, think of acinic cell tumor. And remember, I asked you to check PD1, PDL1 in acinar cell carcinoma. Has anybody checked? We have 3 more slides. You have some time. Check the literature. See, these are more solid cells. And the diagnosis is acinar cell carcinoma, acinar pattern. I have not shown this pattern in this slide. If I give this slide, this looks like more rosettes, isn't it? So, but when you do basement PAS diastase, you can see the nice basement membrane. So this is acinar cell carcinoma. It can have any pattern, acinar, microcystic, papillary, cystic, solid. They will show prominent nucleoli and tumor associated lymphoid proliferation and NR4A3. Previously, we used to do SOX10 DOG1. Now we do directly NR4A3. Very specific. Case number 13, 66 male parotid lesion. Gland is here, some infiltrating tumor.
Myoepithelial carcinoma, they've written.
Prominent nucleoli. The patient, these are all poorly differentiated carcinoma. You have to give a differential diagnosis, and the patient had previous history of melanoma. Okay, that's how we did only HMB45, and it's nicely positive. Okay, that's why before doing IHC, give a call to clinician. They will have a lot of surprises in their sleeves. Okay. Sir, it looks like melanoma, sir. Is there any history? Yes, patient has melanoma. Why you are not told me, sir? I want to test whether you can diagnose by yourself. Okay, that's the answer I get from my surgeons. They are putting tests for pathologists, but you have to understand patient is under stress. So no testing in between the pathologists or surgeons. They have to sit together and come with. So the learning point from this case, before doing IHC, please call the clinician. It won't cost you anything because nowadays we call by WhatsApp, which is totally free. Okay, and you can save lots of money. Another best thing you can do, if the previous surgery is done in your own institute, you can pull the slides and look at morphology. If the morphology of the previous specimen and previous case and this case is similar, without IHC, you can diagnose. Previous case reviewed, morphology is very similar to the current presentation. So this is recurrence or metastasis or relapse of the same condition. Metastatic melanoma. Remember, melanoma is one of the greatest mimickers. Always keep melanoma in the differential diagnosis. Case number 14. Parotid lesion. Circumscribed lesion, lot of very patterns, but you can see nice peripheral palisading. Some cribriforming is there, and stroma is running more over it. Super basal cell adenoma. Okay, and membranous type. Again, the solid type, trabecular type, tubular type, and membranous type. And beta catenin will be very, very useful. I know all of you have beta catenin now in your lab. Many people don't know basal cell adenoma is positive for beta catenin. Okay, please use it and enjoy the staining. The closest DD is adenoid cystic carcinoma. MYB is the diagnosis. In the last case, female parotid, 40 years. So this is again a lot of secretions, but you see only one type of cell. And when you go to the high power, they are looking more squamoid, and some of them are looking more microvesicular. Okay. So there is no hybrid cells here, okay, and there is no goblet cells, mucin secreting cells. These are microvesicular cells. So the diagnosis is secretory carcinoma, okay. So they will look like a follicular adenoma in salivary gland, okay, with a lot of secretions, and the mammoglobin may be positive, but now we have the track. So you are in correct track if you do pan track, okay. And I want to introduce another reference, John Rosai collection. When you put rosaicollection.org, it will take to this picture, to this website. And when you click the slides here, you will see the whole slide image. Okay. Along with the USCP, the Leica scanning people, they scanned the whole slide image of Dr. Rosai's collection. There are more than 10,000 slides available there. You can go and you can type in the search salivary gland, or salivary gland tumor will come, lung tumors, all lung tumors will come. You can play around in this site. Please remember rosaicollection.org. And thank you very much.